Hi, my name is Dr. Marco Caminiti, and you will be seeing me shortly with regards to a consult for potential corrective jaw surgery. I'm an oral maxillofacial surgeon practicing here in Toronto and at the University of Toronto. I'm the program director for the residency program and the graduate program at the Faculty of Dentistry. And I put together this video more to be able to have some communication for you to meet me virtually, but also when we meet for the consultation, there are a number of things that I want to make sure that you understand before you embark on this journey. Corrective jaw surgery is a big step. It's not a small surgery. I really want patients to be engaged in the whole process and to understand what's going to happen. I always like to say we don't like surprises, so part of this video is to tell you what may potentially happen so that when it does happen, it's not so much of a shock. So I will be blending in a number of topics, and this will help you introduce the topic, and when you see me, we can have an open discussion on a number of things. The consultation as well does two things. It gets me information about what issues you may be having. The first thing we're going to do is take some measurements and look at exactly what the problem might be. But also, it's an opportunity for you to learn about what we're able to do. And in that exchange, I also need for you to be your best advocate. You have to speak about what you like, what you don't like. You probably have in your hand a small brochure about jaw surgery, and I encourage you to read through that. There's also a small video link, so if you hover your camera over the QR code on the bottom left there, it goes on to a video that's produced by the American Association of Oral Maxillofacial Surgeons, and it's a very good video of describing. I even stole some of the videos in this presentation, and it also has some patients who talk about their experience. I find that some of these, and especially the American Association of Oral Maxillofacial Surgeons, has great educational videos that you should explore a little bit more reliable than a YouTube or a Google search. So why are you coming to see us for potential jaw surgery? Well, most of the reasons it's because of the bite. Your orthodontist may have sent you because your bite is in a position where braces alone will not fix it. Sometimes patients will have some lip incompetency because they have a large anterior open bite or the teeth don't meet in the front. Some people are seeing me because they have respiratory problems, including sleep apnea. Some patients have had trauma and the jaw bones are not positioned properly, and also some psychosocial disabilities because of the discrepancies that you may have. A lot of it might also have to do with aesthetics, either bone, the skeletal, the teeth, or the soft tissue, and we're able to resolve some of these things with corrective jaw surgery. And some of you might be also present for looking at replacing the jaw joints or added surgery to the jaw joints, which are all combined in one area. So these problems, how common are they? Well, some numbers, just to get an idea for the position. So we like to classify the way the jaws are structured. So a normal class 1 position, for example, is a jaw like mine, where things are straight. Now, I've had orthodontics. I've also had a little bit of surgery, not as extensive jaw surgery, but this was all related in trying to get the bite properly positioned. So this is a class 1 position. A class 2 typically, as you can see on the upper right hand side, is a little deficient jaw. So about 10% in North American sample population have this class 2 position. But a small number of these people need to be treated with surgery. A lot of them can be dealt with compensatory orthodontic movement alone. Class 3 is the opposite, a very large jaw or an underbite. Fewer people have this underbite, about 3%, but if you have an underbite, the chances of requiring surgery are a little bit higher because orthodontically it's harder to treat. This video just shows what we call a double jaw surgery. About 80%, 85% of the surgeries that we do involve the upper and lower jaw. We're basically taking the bone after the teeth have been straightened, the bones are repositioned, and then small fixation screws and plates, and I'll go into detail what that means, are placed so that everything fits together nicely. We have two jaws. If we can get away with doing surgery on just one jaw, we will. But oftentimes, in order to get perfect symmetry and leveling, it's with two jaw surgery. I also joke with patients saying it's not double. If we do one jaw versus two jaw, many times after surgery, patients don't even know if I did the upper or the lower jaw. The swelling, bruising, bleeding, the loss of function is always the same. So you have to be able to trust us saying we'll provide you with what we think is the best surgical option for you. Here, for example, is a patient I did many years ago who had no temporomandibular joint on the one side. This is her pictures before surgery, and this is what a typical x-ray looks like after surgery. You can see on the right-hand side all the plates and screws, but the jaw is now straight. She also had a genioplasty, so the chin was advanced to get better lip competency, as you can see here. She also had two little screws here that are placed there to hold her rib. So part of her rib was harvested and transplanted to replace her joint. These days, more and more, I'm using behind me here a total joint that's a custom-made prosthesis. But these are some of the results that we can get with jaw surgery and the projection, and it's all based on the bite. So the goal of treatment is to make all the facial structures normalized. And putting things where they belong is actually what aesthetics is. So we try to obtain optimal aesthetics, because I'm able to take the upper jaw and move it around, the lower jaw and move it around, and put them together where the bite is ideal. But where I put this is really based on facial aesthetics and what we think is normal, and what you share with me as to where you'd like to see things change or different, or maybe not even changed at all. Here's another video showing an open bite. This is about 30% of the patients that I see will have this large open bite where the teeth don't meet. This is frustrating for orthognathics to use. You can see in the cartoon how a segment of bone is removed, the upper jaw is repositioned, and those titanium plates are placed. In this video, you can see someone with a very large lower jaw, so the big underbite. And what's done is the upper jaw is cut in specific strategic spots, and then the dentition, the teeth are positioned according to guides that are made. There's a lot of behind the scenes work prior to surgery. The actual surgery itself doesn't take very long, and it doesn't take long because of the planning that we do beforehand. So here you can see the jaw being repositioned, and the titanium plates are held there in place to allow the bone to heal immobilized, and then essentially these plates you don't need after a while, but we leave them in place. In this video just showing a patient that I saw who has mandibular deficiency. So mandibular deficiency is treated with the lower jaw, sometimes upper jaw as well, depending on the vertical issues, but that gives you an idea of the projection that occurs. All these videos are nice and nice and clean and neat. Here's an example of a patient with lower jaw before surgery and a year after surgery, the changes that we can make that we get also from an aesthetic standpoint. Here's mandibular excess. So a patient of mine with a very large lower jaw, big underbite, and the method of treatment for that is to take that same sort of surgery, and that surgery on the lower jaw can move it forward or backwards. One of the misconceptions is that we take out a piece of bone, but we don't. Bone is slid across each other. I like to give the analogy of an Oreo cookie. So bone is hard on the outside, but it's soft in the middle. So what we do in our surgeries is we peel apart the Oreo cookie, and then we can slide the two pieces of bone. And once we have the bone in position, according to the teeth, then we put in these little screws that hold everything together. This is an idea. I didn't want to put too many pictures in, but here's a picture of the lower jaw, how the bone is cut. And then when it's repositioned, this is a picture, the image of the small little screws. Sometimes we do jaw surgery for vertical excess or long face, or sometimes what's called a gummy smile. And what we do is remove a portion of the upper jaw. Sometimes in upper jaw surgery, as I showed you with the open bite, but in this case also very narrow cases. There are some times where patients might require 2 surgeries. If the upper jaw is very narrow, the first surgery will be to distract, to expand just the upper jaw to a certain position where it's normalized according to the lower jaw. So that surgery is called a surgically assisted rapid palatal expansion, or a SARPE. I'll be able to explain that if you require it, but a handful of patients might need that if the expansion needs to be a lot, as for example in this young man's case. We may also do surgery for patients who have obstructive sleep apnea, so you may be seeing me because you've been referred by either a sleep center or some other source for the management of difficulty breathing. Now that's an entirely different topic, which I will address if that deals with you. But if, for interest's sake, if you want to hover over the QR code, there is an article that was written for performing a maxillomandibular advancement, which means upper and lower jaw advancing everything, for patients who have sleep apnea. It was written by, at the time was a resident, Dr. Letterhoff. He's now a Newfoundland surgeon, but he did a great little article that he put together. So, what does the overall treatment include? What does this involve? It starts with an initial assessment. The majority of patients I see have already been seen by somebody else or an orthodontist, and it's been determined that in order to get the best result, orthodontics and surgical treatment is required. And so you have a team now. You will require orthodontics prior to jaw surgery. You may have, if you're in your readings, looking at things called surgery first. So I can do surgery first, but I prefer doing surgery early with at least some application of orthodontic mechanics. Your braces can be, the majority of time, are done with full fixed braces. You can have clear aligners such as Invisalign, or sometimes no braces at all if you're a patient, for example, who are seeing me for sleep apnea. The best results, though, are with full fixed metal braces. We can get a 10 on 10 with that. With clear aligners, it's a little bit more of a challenge. We still do get very good outcomes, but it's just not as good as the full fixed. And then without braces at all, sometimes it's hard to control segments. So in that order, you can see the sequence. So generally, your orthodontics can take 6 months, 12, 18 months before you're ready for surgery, because you might need teeth taken out. You will need to get your wisdom teeth taken out. Usually when we do double jaw surgery, the wisdom teeth are in our way, so we do remove them prior to. Part of treatment also includes the digital planning, and I'll explain to that, and I'll show you a video of what that means. But we now do a virtual surgery. Right before surgery, your face will be duplicated with scanned teeth, scanned skin, a CT scan, and I work with engineers in the US that will provide me with surgical guides to help position things. So that's the virtual surgical planning, virtual digital planning, or digital planning. It has a number of names. And from this, we design custom, patient-specific, specific to your case, splints that help guide the bone in position. And then we do orthognathic, or jaw surgery, corrective jaw surgery, and following jaw surgery, you continue with post-surgical care on my part and also by the orthodontist. Overall, this can take anywhere between 2 to 3 years. This is an illustration of a triple jaw. So again, most commonly, that's upper jaw and lower jaw. And we say triple because many times when we involve the lower jaw, we'll also do surgery on the chin to advance it, shorten it, help patients get some lip competency. The surgery itself. Once everything is all set up, we plan for the surgery. It takes about a month of planning, and the surgery is done in the hospital. In Canada, in Ontario, Toronto, we are lucky we have several hospitals that we work at. It's done under a general anesthetic. You may need to see the anesthesia team beforehand, depending on your medical condition, but the procedure depending on if upper, lower chin. I like to give patients something to remember. How long do things take? In general, double jaw surgery can take anywhere between 2 to 3 hours. You stay in hospital 2 to 3 nights. You need to stay at home 2 to 3 weeks. Before you're chewing normally again, it can take 2 to 3 months. And before everything is all said and done is 1 year. The surgery is done on the inside of the mouth. I do not do any puncture marks outside, obviously, unless I'm doing your joints, and then there are scars on the outside. Sometimes I do have to harvest bone. So if I'm doing certain movements in which there's going to be a gap, then I take bone from the patient's hip, and that is transplanted in place. That's all done at the same time. But when we're dealing just with jaw surgery in the mouth, there are no scars outside whatsoever. And we apply titanium plates. These hold everything together. You can see on the bottom left panel. On the upper jaw, you'll have 4 plates and 16 screws. On the lower jaw, you'll have 3 screws on either side, and sometimes screws or plates in the chin. So these are made of titanium. You don't see them. You'll see them on an x-ray. You don't feel them. If you try hard enough, you might be able to feel the little ones that we place near the nose. You don't hear them. They don't set off metal detectors. They don't beep at the airport. And you don't get better Wi-Fi, as some young patient asked me. Immediately after surgery, you're going to stay in hospital. Again, in Canada, we're privileged to have patients stay overnight if it's a single jaw. Double jaw will be 2 to 3 nights stay in hospital. You will have small tubes, depending on the surgery, in one nostril just to help with breathing, another tube in the other nostril just to help empty out the stomach so that there's no nausea, or at least it's limited. There might be dressings on the chin, there might be dressings on the upper lip. This is a typical patient. I made it a little bit small, but this is what someone would look like after surgery. The teeth are held very tightly with elastics. The bite is very delicate. Any movement, even now, if you shift your jaw over 0.5 millimeter, it'll drive you crazy. So we try to keep the bite that we've planned together with tight elastics for about 2 weeks, but you're not wired. You're not wired shut. Those first 2 weeks, I expect complete convalescence. I tell patients you'll leave the hospital after 2 days, and then you go straight to your sofa at home, you grab onto your remote and a subscription to Netflix and a bucket of ice cream, and that's what you do for the next 2 weeks. All surgeons are a little bit particular with their diet. I like to have patients stay on a clear diet for 5 days, so it keeps things nice and clean. Then after that, you can do any blended diet, and then after that, a puree or a soft diet. The first office visit with me is 2 weeks afterwards. I remove all those initial elastics, free everything up, give you some exercises, make sure that the bite is stable, make sure that the wounds are good, and potentially move you on to the next phase of diet. These elastics will be in place usually 2 to 3 months. The second visit is about 6 weeks after surgery. Again, I look at the wounds. You may have a piece of plastic as a splint that's remained, and that is removed at that time. And then I prepare you to go see the orthodontist. So we try to coordinate it that after you see me at that second visit to go back to the orthodontist, and then you'll resume and finish off your orthodontic visit. What are the normal events of surgery? These are things that will happen, and you've all been to Google, and all the patients have their selfies up there. Some are swollen like a pumpkin. Some patients aren't swollen at all. There is a huge variation, and I've been at this 20 years, and every morning when I see patients, it's amazing the difference, even though the surgery may be the same. So I tell everyone, you must expect. You will get bruising, you will get bleeding that comes from the nose and the mouth where the wounds are. You'll have swelling. One side might be more than the other. One side might go away faster than the other. It really doesn't matter. The swelling does go away. You'll have loss of function. You won't be able to chew because of the elastics. You can open enough, just enough maybe to get a straw in. You can use a straw. But with ice and the liquids and the numbness, you'll be drooling because you'll be completely numb for a little while. And it's going to be sore. It is painful. However, if you talk to patients and they explain to you their immediate post-op recovery, they don't remember it, but we make sure after surgery you wake up, you're completely numb, and we give you just the perfect analgesics, painkillers, where you wake up high as a kite and you're happy as can be, and we try to maintain that for a while. Most patients are taking painkillers maybe 4, 5, 6 days after surgery, not for long term. Some patients a few weeks later, as they're eating and chewing, things might get sore, they might need to take an Advil or a Tylenol, but that initial pain is very easy to maintain. And I always talk to patients, say the biggest complaint that I get 2 weeks after surgery, 6 weeks after surgery is food, hungry. Patients are hungry, they can't get things in there. So it's not pain, it's the hunger. We need to have a frank discussion about complications. So, previous slide, those things will happen. Things that are bad. Bad things are surgical risks, and there are 3 that I need you to remember. I'm going to quiz you the second visit, the next consult. I quiz you again when we do our final forms and consent right at the time before the jaw surgery. There is a risk of infection. I like to say the mouth isn't the cleanest place in the world. Even with that diet, with a clear fluid diet, little bits of food, or even debris from the surgery can create small abscesses underneath the skin. Most of these infections are a nuisance. They're very easy to treat, a little bit frustrating. You get mad at me, you know, that I left something behind, but they're easy to manage. But they can occur, and the rate's low, 3%. You will be getting antibiotics right before surgery and throughout your time in hospital. You get large doses for those 2-3 days. I try not to give patients antibiotics afterwards unless they've had a bone graft, simply because it just upsets the stomach, especially because the diet's so modified. Second complication is nerve damage. You saw the cartoons where the bone is cut, and in that area you have 4 little nerves that come out of the jaws here. These nerves will get damaged, they get bruised, they get stretched, sometimes they tear. So what happens is patients will lose sensation. These are the nerves of touch, not of movement. Those are 2 separate nerves. You're not paralyzed, you never will be. But the numbness takes a long time to come back. It'll affect the touch on this area here of the lip and the chin. It'll affect men shaving or women lipstick, food. So for the first month, everything is numb. You won't feel anything at all. Then it starts to tingle back to life. In the upper jaw, most of it will come back after about a month or so. The palate will be numb, probably about 6 months. Most patients don't notice that. It doesn't bother them. Long term, maybe 1% to 2% of patients in the upper jaw might have little corners of the lip or side of the chin where the very light touch doesn't come back. In the lower jaw, the rate is much higher. 10–15% 1 year after surgery. Patients will point out to me little patches of skin that don't come back. The problem is that there's nothing I can do about it. It doesn't affect the movement. As I said, it looks normal, it's not paralyzed, its function is perfectly good. It's just the light touch. Most patients will adapt and learn to work around that deficit. The third risk is I group things called reoperation. There is a small chance that I might need to go back to the operating room to fix something, to adjust something. My reoperation rate is 3%. It's been 3% for years. And it's because what we say is that stuff happens. It could be due to bleeding that's still continuing for a day or even a couple of weeks later. It might be due to an infection that's a little bit larger, and in the clinic I'm unable to scoop out and clean. The plates and screws, that's probably one of the more common reasons we have to reoperate. If you saw in the videos, the screws are very small and they can pull out or get infected. Sometimes the bite shifts. It might shift enough or growth again where it comes to the point where we all look together and say we might need to redo just part of the surgery. Relapse is a struggle both for orthodontists and surgeons. We try to establish a perfect bite and it stays there most of the time. But the odd patient, either muscle pulling or bone and teeth repositioning might happen. But rarely do we have to reoperate for that. And lastly, aesthetic objectives not being met. Some patients come to see me for mostly aesthetic reasons, and if the communication isn't right or I don't obtain exactly what they want, sometimes I might need to make an adjustment. I just wanted to show this is the behind-the-scenes engineering. And this is actually what the costs are related to. Right before surgery, we, duplicate your face. It's sent with these engineers, and right now this is a video that I made with one of my engineers on how I want to reposition the jaw. I put the teeth together, I look at the aesthetics, I try to figure out where the teeth should be positioned, how far forward, how far up and down. From this interaction, I will be getting 2 plastic guides that I use during surgery. And these guides are placed, I cut the upper jaw, and I use the guide, and it'll tell me where to put the upper jaw. Then we sew everything up. Then we do the lower jaw, we cut it, and I use a second guide. It tells me where to position things. So these splints that you'll hear us talk about are critical. They are what make the surgery very accurate and also very rapid. Surgery like this 20 years ago would take double the time. Now with these advancements, with the digital planning and splints, it's really changed things tremendously. Here's a young lady that we treated several years ago. She has a certain degree of vertical height. She has what's called a cant. She has a small lower jaw, a small chin. So she gets a triple jaw. So that's a double jaw plus a chin. I do all the virtual planning. I have all my regular x-rays that are taken. These are taken from the orthodontist. You can see in some areas where there's unevenness in the bone because of that cant. The patient goes to a CT scanner. We put fiducial markers. We put little wax bites to tell us where things are. And this is the outcome 1 year after surgery. And all this outcome is based on the bite. The orthodontist has made the teeth perfectly straight. Then I take the jaw bones and I put the jaw bones in that perfect occlusion. And when you put everything in the right place, that's what aesthetics is. So a nice change for this young lady. This is a typical picture of the x-rays that you will see. Upper jaw, 4 plates and 16 screws. Lower jaw, 3 screws on the right, 3 screws on the left. And the chin will have either 2 screws or a small plate like this. This is typical. Again, it's titanium. You'll never know they're there, and they very rarely need to be removed. This is what she would look like 1 year after surgery. You'll be seeing me not only 6 weeks after surgery, but 3 months after surgery for follow-up, 6 months, and then 1 year where we take our final records. The last item I want to talk about are other sort of bad news things, the costs. So in Ontario, orthognathic surgery, corrective jaw surgery, is covered by the Ministry of Health. It has to be done in the hospital. The ministry will cover anything that's done in the hospital. So when you walk in there, anesthesia, nursing, surgery, recovery room, post-operative stay, you stay in the hospital 2-3 nights. If you really like the food, you can stay 4 nights. That's all covered by OHIP. And to give you an idea of what those costs would be for a non-resident, it's about $20,000 to $30,000. So it's considerable. But OHIP doesn't cover anything else. It's not going to cover your orthodontics. So anything that's considered dental, it won't cover. So the orthodontic portion, it won't cover my engineering. And this engineering is not cheap, and depending on the surgery that you have, today at the consultation, you will be given an exact estimate of what might be required. Also, the teeth. You may need some teeth out. As I told you, you will need your wisdom teeth out. That is not covered by OHIP. The other bad news are wait lists. One of the reasons I'm doing this video is to be able to communicate better and faster, more consistently with patients, because we have a high volume of patients that we're seeing, and I just don't want to miss anything. The wait lists for the consults can be anywhere between 3 to 5 months, and wait list for surgery can be anywhere between 5 to 7 months. For that, we just ask for your patience. And the reason I mention that is sometimes patients are all keen that, oh, I'm ready for surgery. My orthodontist said I'm ready. Can I book next Monday at 10 o'clock? It's hard. We have both treatment coordinators from the orthodontist and from my team that will work together with you to find the right time. However, the surgery is not booked until your orthodontist commits to me that the bite is in the proper position. And finally, the last part are the students, residents, fellows. I'm a university prof, I'm program director, so you always have students, sometimes dental students. You will have residents, and these are oral maxillofacial surgery residents, so they are trained dentists and physicians who are training to do this specialty. And I also have fellows. Fellows are oral maxillofacial surgeons who are spending a year with me to be super specialized in orthognathic surgery. You need to be comfortable with them. If you're uncomfortable with a student or resident, just let me know, and we can change things. But please understand, I do the surgery, but I can't do this alone. I need that team to help me out, so they'll always be around. The last little slide is just if you want to get further into it, I'm going to be doing another video on your post-operative care, very detailed about diet and everything. But if you want to scan the QR code, at least you'll get an idea of what patients get as instructions after surgery. And this is specific to me. You have to be careful because each one of us, even within my practice, we all do jaw surgery, and we all have small nuances. So for example, I like clear diet. One of my partners doesn't like it. He wants full diet. So you have to be careful. It doesn't adapt to all surgeons. So although it is a pretty good guide, I think. Otherwise, I look forward to meeting with you shortly. And always don't be shy to discuss with the treatment coordinators, either mine or your orthodontist, about further steps and plan. And I'll see you soon.